Hello to everyone. So today, I'm Wan Muhammad Mukhliff and my group will be present to you the case study of thalassemia. So one of my group member, which is Mr. Khairul Izzat, Noor Izzati, Siti Jumaiah, and also Siti Roshaiyu. So this is the article that we get for the case study, which is a child lost to follow carrying Beta Thalassemia Major, a case report. Okay, let's go deeper. So basically, what the case study stated is there's a 5.5 years old girl from Maldives presented to emergency unit. So she's ill looking, have some cough, dyspnea, irritability, and fatigue, but no fever. There has no family history, blood related disorder or genetic disease. And also based on the physical examination, it shows that fingernails and skin whitish tinge and sclera shows pallor, skin ashen gray in color, such in this figure, and appeared dehydrated and body weight around 13.11 kilo, underbuilt and malnourished. So she has decayed upper tooth, not associated with pain or swelling. So head and neck examination shows that depicting the classified chipmunk faces as shown here. She also shows no enlargement of spleen, ophthalmologic, which is the eyes, and audiologic were normal, which is the ear. So the hematology find out that the hemoglobin of which is 4.5 gram per deciliter with microcytic hypochromic anemia with anisocytosis, poikilocytosis with nucleated red blood cells. So the HB electrophoresis shows absent HbA, elevated level of HbA2, and increased SBF, which is tally with beta thalassemia major. So continue with the lab report, which is the HIV, hepatitis B, and hepatitis was negative. So the liver and renal function tests were normal, and the result for ferritin was 3,562.69 nanogram per mil. So the hemoglobin was 7.5 milligram per deciliter after she was transfused with a pint of PEG cell and discharged. For the patient plan was she was hospitalized every 20 days for liver and thyroid function test and transfusion of PEG RBC. And that's the case report on this patient. And unfortunately, after about 16 days, she has been passed away. Thank you. And I'll give next to my friend. Thank you.
Assalamualaikum. My name is Siti Roshaiyu. Now, I would like to explain about the causes, the etiology, and the pathophysiology of this case study. From the case study, I can say that this case was caused by beta thalassemia major. From what I learned, beta thalassemia major is an inherited autosomal recessive disorder characterized by a defect in the synthesis of beta globin chains of hemoglobin. Next slide. The etiology of this case is the genetic inheritance where beta thalassemia major is caused by mutation of the HBB gene, which provide instruction for making beta globin chains. In beta thalassemia major, there are mutations that severely reduce or completely prevent the production of beta globin chains. Moving on, the pathophysiology of the case study. Next slide. The pathophysiology of beta thalassemia major can be explained as follows. First, lack of beta globin and reduced functional hemoglobin. In beta thalassemia major, there is a lack of beta globin production due to genetic mutation in the HBB gene. The reduced amount of beta globin leads to a decreased production of functional hemoglobin. Next, abnormal red blood cell development and hemolytic anemia. Without sufficient functional hemoglobin, red blood cells do not develop normally. In beta thalassemia major, the defective hemoglobin synthesis results in a shortage of mature RBC, leading to anemia characterized by a low red blood cell count, decreased hemoglobin levels, and microcytic hypochromic red blood cells. Third is ineffective erythrophoresis. The impaired production of beta globin chains leads to ineffective erythropoiesis, which refers to inefficient formation of RBC in the bone marrow. The abnormal development and destruction of RBC precursor further contribute to the anemia observed in beta thalassemia major. Next is extramedullary hematopoiesis and iron overload. To compensate for inadequate production of RBC, the body initiates extramedullary hematopoiesis, where RBC production occurs outside the bone marrow, primarily in the spleen and liver. This extramedullary hematopoiesis is a compensatory mechanism to meet the body demand for RBC. Next, iron overload and bone marrow expansion. The excessive demand for RBC production and extramedullary hematopoiesis can result in bone marrow expansion to accommodate increased red blood cell production. This expansion contribute to the characteristic of craniofacial changes seen in Beta Thalassemia Major, such as maxillary expansion, bossing of the skull, and other skeletal abnormalities. This can be performed with the patient. This can be confirmed with the patient in the case study who are reported the pathophysiology of reduced hemoglobin synthesis, hemolytic anemia, the clinical manifestation, blood transfusion received by patient, the iron overload episode, and iron chelating therapy. That's all from me. I pass to my friend. Thank you.
Assalamualaikum, I'm Noor Izzati. I will explain on the clinical features. Generally, affected infants exhibit symptoms within the first 2 years of life, often between 3 and 6 months after birth. This is because during this period, infants still produce fetal hemoglobin, and this process uses free alpha chain. The full or classic description of beta thalassemia major tends to primarily occur in developing countries. Most individuals will not develop the severe symptoms listed below, such as severe anemia associated with fatigue, weakness, shortness of breath or dyspnea, dizziness, headache, jaundice, failure to thrive, pallor, hepatomegaly, splenomegaly, and if left untreated, chipmunk faces appearance will develop. This is when facial bones are affected. If it can result in distinctive facial features including an abnormally prominent forehead, full cheekbones, a depressed bridge of the nose, and overgrowth of the upper jaw, thus exposing the upper teeth. Next slide, please. Okay, for this case study, the clinical features include cough, dyspnea, irritability, fatigue, but no fever when this 5.5-year-old girl presented to the emergency unit. On physical examination, patient was ill-looking, however, her vitals were stable. She was clinically anemic. Patient fingernails and skin extremities exhibit whitish tinge and sclera showed pallor. She appeared failure to thrive as she had a body weight of 13.11 kg. She was underbuilt, undernourished with short stature, with evident icterus and yellow tinged fingernail, which is the technical term for jaundice. And she depicted the classical chipmunk faces upon head and neck examination showed maxillary expansion, retracted upper lip and saddle nose altogether. Intraoral examination showed localized periodontitis and broken teeth in lower anterior aspect as shown as in picture. Her abdominal examination, however, didn't show sign of enlargement of spleen. Her ophthalmologic and audiologic examination were done and were within the normal limit. For the next part, I will pass to my friend Izzat. Thank you.
Hi and Assalamualaikum. My name is Izzat. I'm going to present about the lab diagnosis that has been done on the patient. There are basically three lab diagnosis, which is the first one is a complete blood count. The complete blood count results show that decreased MCV, which is mean corpuscle volume, to see, and then the decreased MCH, mean corpuscle hemoglobin, which to the amount of hemoglobin per RBC, and then the result also show the decreased MCHB, mean corpuscle hemoglobin concentration. All the results show that patient indicate severe microcytic hypochromic anemia. And the next slide. The second lab test that has been done to the patient is peripheral blood film PBS. The blood film PBS show that the cell show the anisocytosis, which is very variable in size. So the most the cell show pale in color, which is hypochromic, and small in size, which is microcytic. The second one is poikilocytosis, which is a variation in shape. the slide show, the RBC slide show on the patient show that patient have mainly have podocyte, which is the target cell in the picture, and then cytocyte, which is fragmented part of RBC, irregular shape, jagged or two-pointed end of shape due to the mechanical destruction. And then the results show that patient also have nucleated RBC that show that a very high demand for bone marrow to produce RBC, and immature RBC are being released to the circulation. So the last result for PBS at the showing the holy jewel body, which is show that fragment of DNA due to the inappropriate removal of nucleus. So the next slide is the last slide. The last test that has been done to the patient is hemoglobin electrophoresis, which is the confirmation test. The band, the electrophoresis band was compared to the normal and the B major band. So the patient electrophoresis result show that there is no HbA band. However, increase in HbA2 and HbF band that to cover up the loss of HbA. So the result confirm that 100% that patient have thalassemia B major. So that's all. I'm going to pass to my friend.
Thank you, Mr. Izzat. I'm Siti Jumaiah. Assalamualaikum to all of you. I will explain about the treatment and medication of thalassemia. The treatment of thalassemia aims to manage symptoms, improve quality of life, and prevent complication. Here are some common approach to thalassemia treatment. First is blood transfusion. Regular blood transfusion are often a key component of thalassemia treatment. Transfusion provide healthy red blood cell to replace defective one, improving oxygen delivery and elevating symptom of anemia. The second one is iron chelation therapy. Thalassemia patients who receive frequent blood transfusion may accumulate excess iron in their body, which can lead to organ damage. Iron chelation therapy involves the use of medication that bind to or remove excess iron from the body, reducing the risk of iron overload related complication. The third one is folic acid supplementation. Thalassemia patient may require folic acid supplementation. Folic acid is essential for the production of healthy red blood cell and can help in optimizing their formation and function. The fourth one is bone marrow transplantation. For severe cases of thalassemia, a bone marrow transplant may be considered. This procedure involves replacing the faulty bone marrow cell responsible for producing abnormal red blood cell with healthy donor cell. Okay, fifth is gene therapy. The aim is to correct the underlying genetic mutation responsible for thalassemia by introducing normal gene into a patient cell. Okay, the last one is care. Thalassemia patients require ongoing medical care and monitoring. This includes regular checkup, laboratory tests to assess iron level and organ function, and managing associated complications such as infection, bone abnormalities, and hormonal imbalance. Supportive care also involves providing psychological support and counseling to the patient and their family to cope with the challenge of living with thalassemia. That's all from us about thalassemia. Thank you. Okay, this is our reference.